So moving on to then the afternoon session, we've got Dr. Moyad Alazam, who's here to talk to us about this kind of medico-legal landscape in gynecology. Thank you.
Good afternoon, everybody. Apologies. Good afternoon, everybody. My name is Moyad Alazam. I'm a consultant in Oxford. I hope you hear me very clear. Sorry, my voice is, half of it is gone completely. It's really the medical legal or the negligence in gyne-oncology or gynecology in general falls into a number of rhythms and trends, which I want to explore with you and share with you some of my own experiences. And then we also kind of think together about different things. I was chatting earlier to John. There is a technique that I tend to do, especially with the consent form that I talk to the patients, because I think personally, talking from a center gynecologist to a lead gynecologist, you do the harder job because you deal most of the times with that gray area. When it comes to us, it's pretty much done deal. So all what we have to do is provide maybe an advanced technical advice or technical service in terms of surgery. So basically, I'll talk about the legal tests that we apply, the causes and the drivers for litigation where patients complain, and that's tried from my own experience and what has been also reported there, out there. A lot of case studies, some I know the answer to, some I don't. And then I have, kind of, if no one is going to ask me, I have a few questions for you and, for a couple of cases, take your input in this. Before I go on, please, for the people who take pictures, etc., some of the information within the slide is confidential, related to real patients, real cases in the court. Some of them are solved, others are still ongoing, so they are not to be shared. By all means, you can have them for your own learning, but I would appreciate if they are not shared at all. So there are 3 legal tests. The first and the last, everybody pretty much knows about them, is the Bolam and the Montegemro. The little one in the middle is pretty much which is the forgotten. And I think, without knowing the 3 legal tests, because these are the pillars of the medical legal decisions and practice within the UK, we would, you won't be able to understand sometimes the rationale behind why the decision went one way or the other. So the Bolam, and I know it's been mentioned earlier on, is practically is a gentleman who had a severe depression. He used to have electroconversion treatment, and at the time there were 2 types of practices, some with sedation and restraint, and the other one without. And then it happened one time that he went to the hospital for treatment, and he electively went there, was not given restraint, was not given sedation, and ended by multiple fractures. So he saw the hospital that he was treated in, but that was declined, and the idea is there was a responsible body of practice that practice one way or the other. So it wasn't not giving him the restraint or the sedation wasn't a breach of a duty in essence, and therefore the hospital or the trust were not liable. The second more important kind of refinement, if you want to call it in this way, to Bolam was the Bolitho case. And the Bolitho case is related to a child about 2 to 3 years old who used to have difficulty of breathing, was admitted at one stage to the hospital, treated, discharged. The day after, he came again with the same problems. The registrar was bleeped, the pediatric registrar was bleeped. She, because, kind of the records say that it was she. She was in the clinic. She could not attend to see the child. Bleeped the SHO. At the time, they used to have the pagers. So the pager, the battery went off. The SHO didn't know. You see where it is heading. So they need the phone again. Registrar unable to get from the clinic. Bleep the SHO. Cutting the story short, the child died. Sorry, we lost the picture there. Yeah. So the child died. So the mother of that child made a complaint against the trust. And with that, 8 experts were brought into the case. And this is where it's very important. And I think, this is where I think most of the complex decisions rely on this. So there were 8 experts for that case. 5 said that should the registrar attended, she would have intubated the child, and the child would have been alive by then. 3 completely disagreed and said intubation was not indicated at the time. So we had 2 conflict opinions by experts. So, and that's where the judge, the case reached to the House of Lords. So there were a number of things. Was there a breach of a duty? And if there was a breach of a duty, did that breach of a duty resulted in harm, i.e. the causation? And if so, what is the magnitude of this? And I think, it's important. And because the BOLEM, everything up until that stage was based responsible body of practitioners, okay? So if 20 or 30% of OBGYN societies all over, wherever they are in the world, are practicing certain type and, of a practice, and prior to this, you came up to the court, you would expect to say, well, I acted reasonably. So that was kind of something to the court to decide. So from there, the court has decided, well, actually the registrar breached the duty. But they did not find that the registrar made a harm by breaching the duty. And that shifted a little bit of the emphasis on the claimants from a legal point of view. So while the registrar was in a breach because she did not attend the child, having attended and within, that emergency, and did not intubate because she said that she was not going to intubate. So the child would have, died either way. So the judge took the justification or the opinion of the experts as a reasonable, and therefore the clinician or the trust, they were negligent for causation, okay? So that's where that amendment or refinement to BOLEM test came. Wherever there are 2 conflicting thoughts of work or studies or opinions or choices, call it whatever you want to call it, because we are going to go through this. The court has their, the right to refuse one of the opinion or, based on it can overrule that responsible body within the profession. And for that opinion to stand in the court of justice, it has to be justifiable and it has to withstand the legal test, the legal scrutiny associated with it. And I think these are quite important because it's not good enough nowadays to say, was actually, you know what, I've done this, it is being reported in the literature, it's recognized way of a treatment, and therefore I'm not liable. You could be, by the way. You could be, because you have your decision for that particular patient, and I will talk about the consent, because I think a big part of it goes with the consent, is a dynamic decision process, and there isn't one size fits all anymore. So we will talk about this. So that is the the court oversight, and then the causation emphasis, because again, I think it's emphasized that even if you breach, does that breach cause a harm? And that's for the people who practice medical legal condition and prognosis and so forth. From the causation, had that harm caused, or breach of duty caused the harm, and if the harm has been caused, what are the consequences of this harm? Then the third refinement, which everybody knows about, is the Montgomery Lancashire Health Board case about the diabetes and the shoulder dystocia and injury to the baby, whereby the mother said, if I was told that there is a chance of shoulder dystocia, I would have ended by having or choosing cesarean section over vaginal delivery. And for that, the definition here is, again, went from rather informing the patients about the risks and what we believe is relevant or non-relevant, to talk to them, and this is the most difficult part, and I'm sorry, I wanted Trace to be here because I wanted to debate a little bit of the endometrial cancer, because I was going to put a slide on the decision for endometrial cancer. And when I saw her talk, I thought I will leave it and then I'll bring it for discussion. So that's where really your prejudice as a clinician or your beliefs as a clinician should set aside when you do the consent form. And this is hard. This is extremely difficult job to do because we are not trained that way. We are trained to provide an advice or give an opinion, and also provide, say, hysterectomy, whatever, myomectomy, etc. So there is a little bit, and I always say medicine is like religion. Everyone has a belief. You cannot say to person, don't believe in this, because they might believe. And it's not sometimes we control it. It's inherited within our psychology as a human being. So we need to be careful when we consent the patients, because this is quite tricky part of the medical legal side. So you know the ruling and you know the impact. So really I want to move on to a little bit of my practice and then focus more on the case study going on, because knowing these three cases, three pillars, you can really start thinking about what are the legal consequences for whatever decision we make. So from what I do, I see there are kind of main problems, or where the litigations or the opinions that come through asking me. One trend is delay in diagnosis, and the majority of these coming from the primary care for a patient who has been having mostly lower abdominal pain, blah, blah, etc., and then turn to be ovarian cancer, or failure to interpret the results, and the people who do colposcopy, cervical cancer, they know there are a lot of cases coming through regarding the smear and misinterpretation, because automatically when we have a patient with abnormal diagnosed cervical cancer, that automatically trigger an audit for the previous smears and so forth. And every now and then we have a case that has been labeled as a borderline or cervical anomaly, where it was actually severe dyskaryosis, and that might go at certain, in certain cases up to 10, 15 years back, and that would have been a preventable disease by then. The story of failure to act, and I'm sure everyone of us had the experience of that, is, kind of, you do the hysteroscopy, your colleague do the hysteroscopy, or whoever is doing the hysteroscopy, you look at the uterus, you don't feel you're not particularly worried, your guards go down, especially when it is a polyp, you take it out, you send it for routine histology. That routine histology, if it is not picked up within time and acted on a time, it might be atypical hyperplasia or something. The story of atypical hyperplasia is very common actually, and because of the volume and the sheer volume of hysteroscopies and biopsies, if, we ourselves, we missed a patient, kind of what was sitting for somebody to, kind of sign off the histology on the EPR for about 3 months or 4 months when it was diagnosed cancer. And simply because the guards were off, the endometrium did not look particularly suspicious. So be aware of these things. They are all happening. They are all real life scenarios. Consent is the biggest part of your problem and my problem in terms of the legal issues come in. You do the procedure, you have a feeling that you have done a great job. 5-6 years down the line, there is a complaint and there is, a legal case, and then start evolving, and then you discover there are things that you maybe haven't thought about them, or we did the consent in a way where it's what we thought we are doing was not perceived in the same way by the patient, and that's kind of, it's important. We will talk about this, what the consent, how does it stand, and again, I do a certain way of doing the consent, which I would love to share it with you. And I've took that technique from the group in Wisconsin. We had the pleasure of the author speaking to us a few years ago. And then in the surgical, you do intervention that's not been consented, and that's, if we feel sometimes that we need to do this, a bit of adhesiolysis, a bit of this, you end by injuring. It's not life-threatening, it's not part of the operation. However, by performing it, you end by, resulting in injury. This injury could be life-threatening. You need to be I'm not saying if there is something wrong, do it. It will be better to have a second opinion to the merits of doing it or not. Don't take, all the responsibility in your shoulders. If the small bowel is adherent and it's away from your field, the woman doesn't have any, symptoms with bowel obstruction, don't feel tempted. Before feeling tempted, ask maybe a general surgeon to have a look, have a second opinion, because it's very important when we see part of, the testimony or the defense or the statements, if there was a multidisciplinary input and the procedure was done in the best interest of the patient, that makes, the case much stronger. Complications, especially the ones either undiagnosed or, late action, and then the documentation. And then honestly, the documentation is quite big in terms of the litigation, because, and again, I will bring it as an example, is you do the laparoscopic hysterectomy or the open hysterectomy, 3 pedicle hysterectomy, abdomen checked, no bleeding, signature, okay? Patient comes back, and then there is a bowel injury. Are you negligent or not? We'll come to that. I have a case that I reviewed. So just make sure if you did not check the bowel, because if you didn't say, I checked the bowel and there was no bowel injury, as somebody who is coming to look and read, the operating note, I would say it's actually lacking the, the details. I don't know whether you checked it or not. It's these things that we have to be careful of. Decision making and timings. It's not good enough in medicine to take the right decision in the wrong time. Whether it is a decision to treat or not to treat or to act on a complication. So the decision has to be in the right time. delayed decision, especially with regard to the complication, might cause a breach of a duty, and often is a breach of a duty, to be honest. So this is the first case, and that is published case on the NHS website. And this is a woman who is called GM. She was in her mid-40s by then. She had menorrhagia. She had fibroids. Referred with fibroids. Nothing specific or special about the look of the fibroids. I've seen the gynecologist. The operation went fine. It happened in 2016. The gynecologist, his practice is for women who are in their mid-40s to remove the ovaries. That wasn't, he talked about the hysterectomy, didn't discuss much of another option because she had the Mirena and the hormonal treatment failed prior to this. Okay, so 5-6 years down the line, the case was brought to the court. So what do you think the woman had complained about here? Menopause, correct. And where does that fall? Consent, okay. And sorry, you are mentioning it. And where that part from the consent falls?
Complications of the procedure, long-term effects.
Effect of the procedure. It's not a complication, it's a non-effect. It's a non-consequence of taking the ovaries out. But that means the options of the patients, were the options laid to the patient correctly or not. And that's when we talk about the shared decision and the informed consent. So that particular patient claimed that the consultant was pretty much talking about the hysterectomy, did not give her any alternative, and she, kind of her expert talked about the embolization, uterine artery embolization, and also she had her ovaries removed. And the argument that she put down is, should these been discussed with her, she would have went for the less invasive procedure, i.e. she wouldn't have gone for the hysterectomy, nor that she would have, taken the option of oophorectomy or removal of the ovary, despite, I'm sure, I haven't seen the consent because it's on the NHS website in the case notes, but I'm sure the consent of, taking the ovaries, menopause, bleeding, etc., everything has been mentioned. So that case the dispute was brought to the court, and the court now applying the legal tests, okay? So there were two parts of the claim. Part one, should she be offered uterine artery embolization? Is that a viable option, responsible option? Yes. Was the hysterectomy another responsible option? Yes. By not offering the myomectomy, which the clinician had declared he didn't offer the myomectomy, had the clinician breached his duty? The court reached the conclusion, no, he did not. Simply because, in a way, I'm sure the clinician unknowingly applied the Bolitho type of judgment, which means, yes, we can do the uterine artery embolization, but the risk of failure 30%, and therefore she could have, potentially claimed that, that was not an effective treatment. So, and her condition was debilitating enough to have more of a definitive treatment. So he was not in a breach of a duty in that particular part of the claim. As for the ovaries, the court concluded that the clinician was in a breach of a duty, and the actions of the clinician resulted in a premature menopause, and therefore the consequences of premature menopause. So, and because saying it's my practice to do it in, some of us will say, before, put certain line, saying kind of, before the age of 40, I don't do it. After the age of 40, I do it. Somewhere I discuss or I somewhere I discuss it. I think it needs to be discussed unless there is, a clear indication one way or the other. A similar case on a younger patient. So this lady was 38 years. The clinician who saw her, or the consultant who saw her, actually agreed with her not to have the ovaries removed. But when she came to the surgery, and that's important, because when do you do consent? You do the consent, okay? The timing of the consent, because most of us will do the consent. I'm hoping everybody's changing now on the day of the surgery. It does not stand up, by the way. It does not stand up at all. And this is a case which has been to the court, and the consent did not stand up. So basically, we will keep your ovaries, comes in, registrar see the patient as we normally, you are operating, your registrar is doing the work for you. Mr. X, Mr. Al-Azam does take the ovary all the time, and all is rectum to prevent the risk of cancer. It's a reasonable justification. Woman just taken back, signed the consent form, blah, blah, etc. She complained, the trusts were negligent, and therefore, the consent did not stand at all. So the key learning point, and I'm just going to put them down here, because decisions and options, it's not what we think, it's what all the viable options are, and we have to portray them to the patient, and we have to make them patient-centered. And a patient-centered does not mean we make a prejudgment, or we are allowed to make a recommendation, but we do not make a judgment about which way or the other. That needs to be left for the patient or whoever is responsible. A comment about the guideline, because that is from the case about Dorset, is the uterine artery embolization. Although that wasn't the guidelines mentioned that at the time, but not following the guidelines wasn't a breach of duty, because they are guidelines, they are not rules. So as long as you have justification, you do not have to follow the guidelines, and I think that's quite important to do that, or deviate from the guidelines. And then the documentation. So very quick words, and the consent about what do we mean about the consent? The capacity, patient is voluntary, make decision without any pressure, it's adequate information, the comprehension, it's specific, it's well documented. This is where I would, recommend to you. I'm sorry I'm putting, I do a lot of teaching, and this is the platform where we have Toby, who from Wisconsin, who gave this called the best case, worst case scenario. Okay? And I will come to this in a way. We do not present so many options. We kind of present by all the time, almost always the time, you have two viable options. And most of them would be related, either we go this pathway or we go that pathway. Endometrial cancer, I see it unfit, a woman who has so many comorbidities, okay? So what are the options? Either you do the hysterectomy or you do for example, the hormonal treatment, correct? So the way how we do it, before we do anything else, we need to present the two likely options, okay? This is option A, and that is option B. Treatment A, surgery. Treatment B, hormonal treatment, okay? Mirena or whatever that hormonal treatment. We would have taken the history, what is important for the patient. Is it the job? Is it walking the dog? Is it taking care of the husband? People have different needs, and their choices are affected by their needs and their lives and habits. And without knowing these, we cannot make an informed choice for them or help them to make an informed choice. So we took all of these and start building what I call the grid, okay? And also taking their clinical history and say to them, ideal is you get the star, you get the surgery, for example, nothing wrong is happening, The worst case scenario, you have the most morbid complication, you die on the table. The reality is the outcome is going to be somewhere if you take that option. Okay? Moving to option B, that was that, and then we tailor it out, and then the most likely level or where things are going to be is somewhere in the middle. Okay? Taking the patient's needs, habits, everything, and their feelings about it. So we move from, and that's the important bit, from describing facts to telling a story and relating this story to the patient needs. Okay? And then from there, we talk about short, long term, okay? And then what we need to do, what do you think about it? You always need to ask this question. What are your thoughts? What do you think? You heard both sides of the argument. What are your thoughts? What's important to you? And then from there, we make the decision am I out of time or, sorry, shall I stop? I'll finish the consent only because this is quite important. And then we make the decision with them or help them. We make a recommendation, actually, and patient is the decision because you are allowed to advise them. You know, we are not 100%. That's where your expertise lies, and my expertise lies by giving the recommendation. Okay, I'll stop here. I'm sorry, it's a long talk, I knew that. Any questions?
We've probably...
Apart from the time management, sorry.
Probably got time for one question.
Thank you. That was a very lovely talk. I'm Nidhi. I'm one of the trainees from Arrow Park Hospital. My question is, if you had any experience about if there was a case you came across from for sterilization, offering just a clip application to a salpingectomy. Recently in my unit, there had been a debate about offering or not offering salpingectomy for sterilization, counting it reduces the risk of cancer, like ovarian peritoneal cancer, but there had been like two groups for and against it, so I just wanted your opinion.
I haven't come across a case, kind of comparing tubal ligation versus removal of the tubes for sterilization. But we go back again to how you make your consent and ask the patient to do the consent. Here, the choice is it's not sterilization versus no sterilization. The choice is, do we take the tubes out? And these are the benefits and these are the risks. And how do you feel about it? And the tubal ligation, these are the benefits and these are the risks. It's a much simpler procedure, less risky. And then ask the patient, what do you feel about it? And that's what would be my advice, because both are viable options.
Thank you.
You're welcome.